right. Good morning, everyone. Good morning. There we go. Mimi. Good morning, brave and hardy souls. Thank you so much for coming out to the Baker Institute this morning. I'm Elena Marks, and I'm a senior fellow in health policy here at the Baker Institute, and I'm part of a group that does work on health system reform, and part of what we work on is healthcare access. And that's obviously what we're here to talk about today. We already have a shortage in Texas of OB-GYNs, and the report we're going to be discussing today shows that that trend is going to only worsen, and that's not good for all of us who live in this state. Before I introduce the panelists, I want to thank our co-sponsors for the event, the Jacob and Therese Hershey Foundation and the Cullen Trust for Healthcare, and a special call out to Elizabeth Love for bringing together 10 funders to make this report possible. And so on with the show, I'm going to introduce our moderator and the panelists, and then they're going to take it away. So our moderator is Mimi Swartz, and if you live in Texas and read anything, you probably know who Mimi is. She's an executive editor at Texas Monthly. She's written a lot of books, including the one called Ticker, which is about the quest for the artificial heart, and it all takes place across the street in the TMC. Her work has also appeared in Vanity Fair, Esquire, Slate, National Geographic, and the New York Times. And our panelists today include Alex Morin. Alex is with Manatt Health, and he's the lead author on today's report, just published this week. He's a managing director at Manatt, where he provides strategic consulting to the healthcare sector. Before Manatt, he worked at Brookings Institution on the same kinds of issues. And as I learned reading your bio, you have a master's from A&M, so you have some connection to Texas. Welcome back. Also, we have with us Dr. Damla Carson, who is an OB-GYN in private practice here in Houston. She's a graduate of Rice, so happy to have you back here at Rice. And she's also on the board of I'll Have What She's Having, which is a nonprofit that advocates for improving access to health care, including abortion care. One of her areas of expertise is complicated pregnancies, including the case of a pregnant woman that's been in the news a lot for a fatal fetal diagnosis, and the harrowing story that woman had to go through. And we also have with us Dr. Todd Ivey, who is practicing OB-GYN in the community for the last 30 years. He's also the chair of our district that includes Texas for ACOG. And so he's very connected with what's going on nationally for the OB-GYN profession. He sees patients and delivers babies right over across the street in the medical center, and he's also involved in training medical students, and he has lived here for 30 years, but he also came here to do his residency, and like so many people, he stayed where he completed his residency. So where you go to school and where you do your residency matters to the practice going forward. And so with that, I'm going to sit down and ask Mimi and our three panelists to come up, and y'all take it away. There will be time at the end for Q&A, so be ready to ask questions at the end. Thanks very much for being with us today.
Are we going to pass? I guess what? Can you all hear us without? Yeah. Oh, okay. Matt, I'm going to let you start. You said you had a slideshow, which I think will start us off. How many of you have read this survey, actually? Yeah, I think we need an intro. Take it away.
Sure. I'm going to come up here if that's all right, and
yes.
Very quickly. All right, so thank you. I'm gonna keep this brief, but I thought we would give sort of the context for this study, where we started, and then talk about what we learned through this important work. And I'm going to move quickly, so there's a lot of slides here I'm not going to address. I'll just note my wonderful colleagues who worked with me on this report. Deborah's joined us. We also had Dr. Daryl Kirch, who's a national advisor with Manatt and former dean, former teaching hospital CEO and the emeritus president of the Association of American Medical Colleges, also on our team. We mentioned our just wonderful funders. I also want to note we had an advisory committee that worked with us on this that included perspectives from medical students, residency program directors, practicing physicians, accreditors, policy and advocacy leaders from across the country and in Texas that were invaluable in bringing this data together and bringing this story to life. I'm going to spend a bit of time on the context. I'll talk about the methods, kind of what's new in this report, and then go through our findings, which will be, I think, the primary items for discussion in our panel. So there's four, I think, things to understand in the context where we begin this work. Sort of why a focus on the workforce, number one, and then number two, why a focus in Texas. And I'm going to go through each of these points. So why a focus on the workforce? We know that the workforce is a component of access to a healthcare system, and access is a major driver of outcomes. In this case, we're looking at reproductive health outcomes. I think it's important to know that it's not the only driver, right? There are other factors that go into a good outcome in a clinical setting: economic stability, your neighborhood, education, food, transportation, different social drivers. But for the purpose of our report, we did focus on access, and within that, we focused on workforce as a major component of it, because it does drive and is important as we think about ensuring good healthcare access for all. Why Texas? So one answer to this question is we are starting from a place of relative weakness with respect to the number of OB-GYN physicians and the distribution of the OB-GYN physicians across the state. This is just a look at the shortage. We're sort of starting, we're going to evolve to what this data is from the HRSA part of HHS that projects a 84% adequacy, meaning we're 16% short. That translates to 760 physicians by 2030. It's an enormous amount of work, manpower that we're going to be facing a deficit on. So we're starting from a place of we have a stretched workforce. We have a workforce that is also geographically challenged in certain regions. The second answer to the question why Texas, we're starting from a place, and this is data that has been well reported. I think you all are familiar with the maternal and other health outcomes in the state, some of the worst in the nation. This is national data that looks at abortion restriction states and abortion access states, and you see the disparity here, and in particular the disparity as you look at minority populations. Really, really stark. And so again, we're starting from a place of weakness in terms of where we are in outcomes. And then the third answer to the question, why Texas? Texas is a big state. We have a large number of physicians. We train a lot of the medical students and residents, more than any other state in the case of medical students than New York, and resident physicians in any other state except for New York and California. And we're one of the states with one of the most severe abortion bans. So that's kind of where we start, right? A workforce that's under stress, outcomes that are poor, and an important state for us to understand as a nation. So what did we do? What did we study? This is a depiction of very a complicated process, sort of boiled down the workforce continuum for physicians. We start with medical education, moving into residency, and then from residency into clinical practice. And our study looked at the transition points along this continuum. So students applying to residency programs, residents making decisions about where to practice, and then amongst the practicing physician community, sentiment about short and long-term professional practice decisions. It is important to note there's sort of a flow here, right? This isn't just Texas. People come to the state for training. They may leave. They may come back. It is fluid, but we are wanting to understand the dynamics here in the state. Our approach was a sort of mixed methods. We had 2 surveys that we fielded, one amongst current physicians, OB-GYN physicians, one amongst current resident physicians, so trainees. Both surveys focused on really two sets of issues. One set of issues relating to how have the Texas abortion laws impacted your practice, or in the case of a trainee, your training. And then we asked questions around how does that translate into your thinking about professional practice? How you're practicing today, if you're a trainee, where you'd like to practice when you complete your training. Different questions, but in those two broad areas. The surveys were distributed to about 3,700 individuals, a subset of which were eligible to complete, and we received 494 responses total. The second input into this study is we did a number of interviews, structured interviews with residency program directors who are responsible for the training at their respective institutions of OB-GYN physicians here in Texas. And we also interviewed a number in Illinois. Why Illinois? Illinois is a state where abortion remains legal and is dealing with the dynamics that we're going to get into in the panel from the opposite side. So they're seeing an increase in patients coming into the state for care. They're figuring out how to manage their own medical education and training programs, and they're seeing influxes of applications. The dynamics are playing itself out in a state like Illinois much differently, and we thought having that comparison would bring some richness to the study. So this is the approach that we took to arrive at our findings, which I'm going to step through very quickly. So finding number one, and this sort of characterizes the whole of the study's findings, which is a significant majority of practicing physicians that we surveyed believe that the Texas abortion laws have inhibited their ability to provide highest quality and medically necessary care to their patients. And this is sort of this is the primary take-home statistic here. I've outlined it in red, which is 71% believe that the abortion laws have had a negative impact on their practice. When we double-click on that, we found 72% believe that they agree or strongly agree with the statement that they cannot provide the best possible medical care for their patients given the abortion laws in place. 76% feel like they can't practice evidence-based medicine, which is what they're trained to do. Further, 29% believe that they don't have a clear understanding of the abortion laws and how to work with their patients to navigate their clinical choices. And 60%, I think this is an important statistic, fear repercussions, civil or criminal, that prevent them from practicing according to evidence-based medicine. So that's where we start, a clear impact on professional practice. And as a result, finding number two, we're seeing that many physicians and resident physicians are considering or have already made changes to their practices that will reduce the availability of OB-GYN care in the state. 44% of physician respondents indicated that they've thought about or have already changed how and where they practice. 1 in 5 have thought about leaving the state. 14% would like to leave to practice in another state but can't for some reason, personal or otherwise. 13% planning to retire early in a workforce that's already rather seasoned, and then other aspects of this dynamic as well. I think this is a very stark warning sign about a potential reduction in the overall workforce. For the resident physicians, 57% indicated that the abortion laws were irrelevant to their decision about whether or not they were going to stay in the state after residency, and of that group, half indicated that these laws contribute to their plans to leave the state. And this is an important component of the workforce to understand. Many who train in a state stay, and we have very good data that backs that up. Finding number three, physicians and resident physicians who are electing to stay are doing so for a myriad of personal and professional reasons. I think we can all appreciate it's a complex calculus. Where do I want to live? Where do I want to train and practice? But one thing that came through loud and clear in our work is many have this desire, and you're going to hear that, I think, with our panelists, to support patients as best they can. Committed to communities, committed to helping patients navigate their healthcare options. I pulled just two quotes that we received as part of this study. One I think is rather impactful. I do not feel I can practice to the full scope of care to my patients, which leads to increasing anger and frustration. I think about leaving Texas every day, yet I feel the need to stay and take care of my patients and fight for their reproductive rights. I think a very clear articulation of that mission orientation that is so important. We wanted to do a double click on the transition from medical school into residency. And we have data nationally. We know applications are dropping in states that have banned abortion in OB-GYN and other medical specialties, by the way. The program directors we talked to acknowledge that. They verified that with us, but do feel that the quality of students that are continuing to match into their programs is good. They're filling their programs every year. But early warning signs, again, of a potential problem in this critical transition point from medical school into residency. This is data for Texas that looks at medical school applications to residency programs here in the state year over year from 2021 through the last cycle, 2023. Really stark data. I'm going to bundle the last two findings together very quickly and wrap up. In order to meet accreditation requirements, so in order for these residency programs to maintain their standing, they're developing and oftentimes underwriting the cost of affiliations with out-of-state programs for complex family planning rotations. In order to get trainees the experience that they need and that they're required to provide, they're having to establish different kinds of relationships with programs to meet that. This is where the engagement with Illinois was so important. They universally acknowledge to us when we spoke to them about the importance of supporting as best they can residents and physicians with abortion restrictions, and they are taking on that responsibility. But there's varying ability and interest to continue to do this, given the complexity of these kinds of arrangements and the number that we need to establish in order to support not just all of the trainees here in Texas, but in all of the banned states. We spent a lot of time talking about this, and I'm happy to go into it more in the panel. It's complex, but what we found is, these arrangements, though required, and many are struggling to get these off the ground, they're very complicated. They're costly to put in place. Think about packing up and moving for 4 weeks to go train in another state when you've got your family here. There's legal issues associated with doing this. You can't just pack up and practice medicine in another state. There's malpractice insurance issues. There's licensure issues. All of that needs to be worked out. There's an impact on each program. The institutions that are sending a resident out of state are losing part of their house staff. They're losing a practicing physician. The accepting institution is trying to fit this new person into their workflow and into their own programs. It's operationally rather complex. And lastly, we heard, while critical, this is a Band-Aid, and the experience is insufficient in many respects. And so what can we conclude from this? I think first and foremost, there's this tension that is very clear to us between these pressures that are now on the physician workforce from the abortion laws and this strong sense of mission and purpose. And we need to continue to monitor that over time. There's early indicators that the abortion laws are prompting personal and professional changes that will likely reduce access over time. And I think lastly, a call to action for more rigorous and regular tracking of data, understanding this dynamic as it's playing out year over year, and I think really turning our attention to strategies that we can develop to support that pipeline from student to trainee and ultimately to clinician. So with that, I'll turn it back to Mimi.
Thank you, Alex. I have two questions just to start about this study. And one is, were you surprised at what you found, or was it a suspicions confirmed sort of thing?
I think for me, suspicions confirmed. Mm-hmm. I think for sure. I think that this tension was the word I used to describe it between the physician community, the resident physician community, to want to stay and practice in this environment, balanced with the pressures of just the reality of delivering care in this environment. That I think came through in a way that I would say was, I was happy to see it, I guess is what I would say, more so than surprised. And I do think we need to understand that calculation, that wrestling that physicians and residents are doing. And again, as I said, support them the best that we can to prevent a stem, to prevent further reduction, but monitor it, because I think the early indicators are rather scary if you play them out.
Yeah. I have a question for all three of you, which is, when I was growing up, the doctor was the leader in the community. And what I've seen now is doctors just being rolled over by our politicians. And so I wonder, how can they get that power back? Why aren't they organized to fight this?
You probably.
I'll be glad
We'll
to
start
speak.
with you.
I mean,
That's fine.
more up your alley, I think.
I think for many years, as we've seen in our state, there's been a gradual chipping away at abortion rights, right? If you look at the history of abortion in the state of Texas, there was even the 1925 statute that was still on the books. So when Roe v. Wade was overturned, our Attorney General clearly said, I will enforce that statute, right? So we've seen this gradual chipping away, whether it's been increased requirements. You had to do an ultrasound, you had to show her the ultrasound, you had to have certain privileges at a hospital, all these things that physicians were required to do. And I think the medical community just went along with this. But now I think these restrictive laws have really crossed the line. And I think they are impacting women's health care. And we are trying to, on a national level as well as a state level, we have to be very strategic in the state of Texas. And as I'm sure you all know, one of the things we're doing is we're doing lunch and learns where we go to the Capitol and we try to educate the staffers about women's health care. And I know y'all heard me say this morning, but just because you're a legislator in the state of Texas doesn't mean you understand health care. And just because you're a physician in the legislature doesn't mean you understand women's health care.
What Donna Howard, a state senator who's worked on this issue forever, told me that these legislators really don't know a fallopian tube from a tire iron. So you're like trying to explain to them how women's bodies work. Is that?
Absolutely. Education of the general public, education of the legislature and our state officials, I think is a big part of what we need to do and what our mission is moving forward.
Have you seen any sort of regret on the expressions of any of these people? Or grasping what they've done?
Do you want me to answer this honestly?
Yeah, please.
So, yes, we have.
Yeah.
And we have identified certain legislators who may say off the record, yeah, this has gone too far, but, I have to vote with my party, And so, unfortunately, this has become a partisan issue.
Yeah.
And this should not be partisan or political or governmental. This is healthcare.
Dr. Karzan, can you talk a little bit about, one of the things you said to me was you talked about the price of complacency. So can you expand on that a little?
Yeah, I mean, I think speaking to what Todd said, they really chipped away, and honestly, it was brilliant, right? Because they were these small, not always small, but these things that weren't big enough to get so much attention, so much response, requiring that an abortion facility be a surgical facility. And on the surface, that makes perfect sense. Yeah. And until I talk to patients and non-OB-GYN colleagues, it just makes it more expensive.
Yeah.
So it's really putting a bigger barrier. With that, the number of abortion clinics in Texas dropped to only a handful. And so, really the whole thing with Roe versus Wade being overturned, that was kind of the final nail in the coffin. The number of my colleagues who said to me that, Roe versus Wade will never be overturned. Yeah. That will never happen. And I said, mark my words, it's coming. Yeah. They've had a long game. And so I think, even patients, for instance, Kate Cox, who many of you are familiar with, and I have her permission to talk about her case because she's talked about it. she said, you know, I really wasn't paying that much attention to the abortion debate because I never thought it would apply to me.
Yeah.
Right? All my pregnancies have been wanted pregnancies. And so I think the key to all of this is that every case is so nuanced and so unique,
Yes.
and really can only be understood in an interaction between a patient and their provider. And it's just such a breach of that relationship. You know, getting back to what you said about physicians standing in the community, it's really interesting because there were some surveys that came out, I can't cite the study, that patients don't trust physicians, don't trust the healthcare system. But when you ask them if they trust their physician, they absolutely do.
Yeah.
And so it's this, it doesn't make a lot of sense to me. I think a lot of it is kind of social media and just how our society has changed over the last few decades.
We talked, both of us, or all three of us, talked about fear. Can you talk a little bit about how it's affected? I mean, one of the things that interested me was it's not just doctors who are afraid, it's nurses who are afraid, it's administrators who are afraid. Can you talk about how that's affected you?
I'm happy to talk about that. I think I've lived that out with the litigation. And even just personal experiences. I mean, nurses don't want their name on the chart. Somebody's having a miscarriage, they're hemorrhaging, and the question is there a heartbeat? Who cares?
Yeah, yeah.
Right? I mean, we shouldn't stop and delay care, and that's exactly what's happening is patients who need care are, you know, bleeding or suffering while, you know, the healthcare system, you know, the administrators, the physicians, the nurses, the scrub techs, everybody has an opinion. And a lot of it's from fear. I had a patient who unfortunately was losing her pregnancy in the second trimester, and instead of leaning in and supporting her and her husband and providing them compassion in this devastating experience, they felt isolated. Her husband was very angry that, you know, nobody came to check on them. Nobody asked them if they needed something more. Just, I mean, forget the actual physical care. So
terrible.
it's devastating.
Yeah.
And I'd like to say just one little
Please.
thing.
Yeah.
It's also created an environment of mistrust within the medical community, right? So you're in there, you're in the situation, and you have to remember we're all still under the effects of SB 8. And SB 8 is what we call the bounty hunter law. So, right? So it incentivizes people who are not even connected, may not even know the patient, all right, to bring civil action against a physician. All right, and there's a financial reward. And then even if the physician is not found liable, the physician cannot go back and countersue for cost. And remember that insurance companies and institutions, malpractice insurance companies and institutions, have made it very clear to practicing physicians that if you are named in one of these actions, you will not be protected. Okay, so it's a little bit frightening for physicians, but you are in there and you're trying to provide good evidence-based quality care, yet you don't know who else is right around there that may come back and bring a liability against you, a civil action against you. So it's created this kind of environment of mistrust. An interesting thing about this too, I had a physician that had a very severe complication in pregnancy and actually ruptured her membranes early, and she wanted to leave the state, and you know, she was asking me about this, and she said, well, will they come after me? And I said, oh, no. They're not going after patients. They're coming after physicians. She goes, but I am a physician.
Oh
So
my
will they
God.
still come after me? And, you know, it even gives patients pause, you know. I just think that was a very moving moment for me.
Horrifying.
Yes.
When we were talking, Todd, about how the fear trickles down, you were saying, you know, we're all thinking about residents because of the survey, but can you talk a little bit about medical students? And who's
Absolutely.
coming also, and what that's going to do.
So after the passage of SB 8, they started looking at other states caught on, and you know Texas was first in this thing, so you all know that. And I would go to a national meeting, and people actually would kind of make fun of Texas, right? And they would say, "Oh, but you know," we would give state reports, and they go, "But at least we're not Texas," you know.
Yeah,
And I
right.
said, "Okay, I get it." I said, "I understand we have some problems in women's health care right now." I said, "But you know, it's us now, but it's not going to be us forever. And so just get ready. And we don't need your criticism. We need your support, right?" And I can't tell you how many people came up and apologized for their comments. But what we saw when they did studies is that 70%, 77% to be exact, of third and fourth year medical students said that these laws were going to affect their choice for a geographic location of which to apply for their residency training. You know, 77%, and that was across our nation. You know, and that frightens me.
Yeah.
You know, and medical students, I work in an academic center, and I'm not speaking on behalf of my institution or my employer. Okay, let me make that clear. I work in an academic center. I had a medical student at my clinic, and I said, "Okay, so tell me what you're thinking, what's your specialty," you know, because you know, you're wanting to bring them, not necessarily into OB-GYN, but into medicine, you know. And she said, "Oh, well, I think she was going into internal medicine." And I said, "Oh, well, you know, we've got some great internal medicine programs in our state." And she goes, "Oh, I'm not saying in Texas," you know. And I was kind of shocked, and I thought, well, you know, I've read the statistics, but wow, really? And I said, "I want you to rethink this, because I'm one of those stubborn people that is not leaving," you know, and, along with Dr. Carson. And she said, "No, I'm leaving. I'm not going to stay here and train." And so it kind of hit home for me that these are real things. These are real things that students think about.
Yeah.
We didn't profile this in the report, but we did ask the program directors in Texas about this dynamic of third and fourth year students who want to go into OB, they do their rotations and they're good, and they want them to come into their own program. And we asked about applications to the home program, and they said, you know, and they have gone down over the last 2 cycles, and they hadn't thought about it. And so that cohort, which we did not study systematically, I want to be clear, we got these anecdotes of this issue of normally you'd see an aspiring OB resident in a good program at least apply, if not match, and that dynamic appears to be shifting a bit.
And I think those applications have gone down in all medical specialties in Texas, like people applying in all medical specialties.
Oh, yeah.
I mean, primarily OB-GYN, yes, but all specialties.
Yeah.
Well, and that, I think, well, Elena and I were talking about this, but quality, you know, I feel like Baylor was a place where, you know, it was one of the best programs in the country. And what are they thinking now? Are they seeing what's going to happen?
Well, we're worried about the brain drain, you
Yeah.
know,
Yeah.
and I speak, I think, for all academic institutions. You know, Texas has typically been an incredible place to get a medical education and medical training.
Yeah.
We've been a physician-friendly state. We had tort reform that was passed in 2003 that was really good, particularly for my specialty. You know, but now we're worried that we're not going to attract the best and the brightest, you know, and I think it's going to be gradual, and I think we're going to see this. And then my biggest fear, and you're helping us with this, is that at one day it's going to really affect access to care. Okay, when women can't get their pap smears and their cancer screening and prenatal care and contraceptive care, and that's a day I hope I don't see, but unfortunately I think if some of this continues, we just might.
Yeah. Do you want
Well,
to
and
add?
I think, yeah, as we've been talking, I've been thinking about, I mean, prior to all of this, there was a big push to try to encourage medical students to go into OB-GYN. You know, as I'm sure you all know, it's not the easiest lifestyle.
Right.
And, you know, we talk a lot about burnout and, you know, very difficult to balance personal and professional life. That work-life balance is harder to strike in OB-GYN, and there have been some changes made. But I think all things being equal, you can understand if you feel equally drawn to two specialties, you might choose the other.
Yeah.
And I think that's going to happen more and more. It was happening prior to the abortion ban. But also, you know, do you choose your family over your professional, you know, when you're deciding where to live? I mean, I am quite certain this is going to affect some of the industries in Texas. Their ability to attract talented employees because they don't want to bring their families to Texas because they have, you know, they have wives and daughters, and so it's going to ripple out from there.
Well, this is a question I have to ask myself as someone who's decided to stay and fight, is when is the legislature going to figure that out, that there's an economic cost to what they've done? And there will be down the road.
You know, my biggest worry with the legislator, and you can probably speak better to this, is they're worried about getting elected today, and there's not a lot of long-term planning. You know, I don't think they can see much further. Most of them cannot see much further than the next election.
Dr. Carson, I'm really interested in, I wondered if you could talk a little bit about your personal transition. I mean, you started out, I assume, as a regular doc, and suddenly you've been pulled into this incredible national debate.
So, honestly, I mean, a lot of my colleagues would think I'm crazy, but I'm grateful to be able to do something. It was such a helpless feeling. You know, the phone call I got when they were looking for plaintiffs in the Zarowski case, one of my colleagues called me, and because of her affiliation with an academic institution, was prohibited from speaking out. And as luck would have it, I had just left an academic institution to start my own practice because of certain beliefs. And, you know, I was single, no children, so a lot of people are worried, you know, abortion providers have been killed, attacked. And so putting yourself in the public eye as an abortion provider, you know, did give me pause. But my colleague who reached out to me said, you know, would you be interested in speaking out on the condition of women's health care in Texas? And I said, do you know me? And she said, that's why I'm calling. So I have a little bit of a reputation as being a fighter, but good and bad, I guess. But I've been actually pleasantly surprised. I've had so many people from my past, from my training in other states, reach out to me in support, patients, some of whom are attorneys who have said, I have friends who have volunteered, they want to support you if you ever need anything. But again, Houston is as someone once told me, a blueberry and a cherry pie. So, yeah.
Well, that's great. Along those lines, this is sort of a philosophical question, but there's a writer named Adam Serwer who wrote a book called The Cruelty is the Point. And I wondered, where do you think this is, you know, who's the burden going to fall on the most? That's sort of rhetorical. But why is this happening? What?
Well, that's a big question.
It's a big question, I know, but
I can just, you know, speak a bit more to some of the themes that concern me, I guess I would say, coming out of this work, which is, you know, the impact of the laws here in Texas. I think there's two dimensions to this that I think are interesting. One is we're not just talking about access to abortion care, right? We're talking about access to any services that OB-GYNs provide, and other medical specialties, by the way, family medicine, emergency medicine, you know, any specialty who sees a pregnant patient, right? And so I think that is a key message in this ongoing dialogue. And then a second, which is sort of a national view that I always think about as somebody who goes around the country. I work with academic centers in all the states. You know, given that Texas produces so many medical students, so many residents, the laws here impact the country, right, in terms of the workforce. And while it is critically important that we focus on how to maintain access here in Texas communities, I think it's also important to acknowledge that the rest of the country, and not just Texas, all the states who have abortion bans, it's affecting the national pipeline, if you will, for physicians. And I think we really need to wrestle with that and figure out, as a country, how can we best stem the impact.
Yeah. Do you want to add to that?
Well,
see
I was
nodding.
just going to say a few statistics that I think are very important. Is the average OB-GYN is 51 years of age. Wow. And the average age of retirement for an OB-GYN is 59.
Yeah.
So we know that we are going to have, in the next decade, like 40% of our workforce move into retirement age. We're expecting nationwide about a shortage of 5,000 OB-GYNs in 2030. And you see how many your data shows.
Exactly.
So I think these are real numbers, and I think that concerns us all. And we need to figure out how we can make this a better environment for OB-GYNs to practice here and attract people into our specialty.
Well, and definitely I feel like our patients are getting more complicated. I mean, it used to be a rare
sure.
thing for me to see a patient in her 40s pregnant.
Oh,
and
right. Yeah.
it's a significant percentage of my practice
Yeah.
now. And so more obesity, more hypertension, more diabetes.
Yes, absolutely.
And the maternal mortality speaks to that as well. I mean, the increase in maternal mortality is staggering.
In the cities as well as in rural areas, as you think?
Well,
Because you've got the poverty in
yes,
the cities. Yeah,
yes.
but then-
Well, and those are the patients who are going to be most impacted by
Oh, yeah.
bans like this, right? The patients who don't have most, middle class and up patients are going to figure out how to get the care they need. I mean, it's going to be a fewer percentage of them that are really trapped because of their situation. I mean, you hear cases like Samantha, who was one of the plaintiffs in the Zarowski case, who was forced to carry and deliver an anencephalic baby because she and her husband share a car.
Right.
They have 4 kids. They can't afford to miss work. So, they're trapped.
Yeah.
They deserve to get care at home. And I don't know what percentage of Texas counties actually don't have an OB-GYN.
About
growth.
50%.
Yeah.
And I'll be glad to
Yeah.
address the rural area issues.
Yeah.
Yeah.
So
Go ahead.
Oh,
Yeah.
well, about 50% of our counties do not have a OB-GYN provider, all right? Now, not a big deal in Houston, not a big deal in Austin, not a big deal in Dallas, El Paso, San Antonio, right? But when you get out, and we started a thing called Levels of Maternal Care, where we go to hospitals and we survey these to help them provide better care to pregnant women, right? And I'm a surveyor for this program. And I went out to Odessa, all right? And I said, so what happens if you have a critically ill mother? Because pregnant women do get critically ill, okay?
Fast.
They can get
In a
critically ill,
hurry.
all right? Very much so. And they said, well, we have to ship them to Lubbock. Well, I don't know the geography of West Texas.
Yeah.
So I said, how far is Lubbock from this? 3 hours.
Yeah.
3 hours. So this is really going to affect our rural areas. All right, we're already seeing hospitals that close in rural areas. They don't want to deal with this. They don't want to deal with how expensive labor and deliveries can be and how low the reimbursements are. So they just get out of the business. We're seeing more referrals into these centers to the larger urban areas. So think about what that does for a family. Right? So they have to relocate, they have childcare issues, they may have families, they may not have family support. It could be very expensive financially. It is not ideal care.
I have patients who routinely drive 2 hours each way for their appointments. And when you're pregnant, there are a lot of appointments.
Yeah.
And we are getting maternity care deserts too around
Right.
our state. That's what we call those.
I mean, we've given our sample size. I mean, all the data that we reported is state. We weren't able to break it down into urban. We asked questions, but our sample size doesn't allow us to do that just yet. But I would venture just to put a finer point on it. These trends, these negative trends, the impact is without question going to hurt rural areas, disadvantaged areas, much, much more, without question. We have enough national data and studies that have looked at this. I think we can make that jump.
So, do you want to add to that, Steve?
No, I'm just agree. I just think this is
Yes.
going to be a really big problem for us, and we're trying to address it nationally as well.
So I think this is good because it's my last question. So what can I do? What can the audience do to help you all and to bring change?
Talk to your legislators.
Yeah. Oh, God.
All right. You know, this is not all about birth control. Abortion is a method of birth control. All right. Most abortions that are provided are not for contraception, you know, and that is, people don't understand that. I think we need to reframe. I think it's a misnomer. I think when you look at these things, this is not about pro-life or pro-choice, okay? I am very pro-life, all right? But I also understand that there is a role for abortion in healthcare, okay? So calling me non-pro-life is not right, all right? This is about choice or non-choice. But that set aside, this is really about healthcare. And women need good, evidence-based, quality healthcare with access to it in our state, the best state in the nation. Sorry. I'm an adopted Texan.
You weren't born here, but you got here as fast as
Yeah.
As fast as I could. That's right.
So
As
do
the
you want
bumper
to add
sticker
to
says.
that?
Oh, use your sphere of influence. I think
Yeah.
that's, you know, I used to not bring this topic up because I didn't want to offend anybody.
Yeah.
And I think as Nancy Northrup, who is the head of the Center for Reproductive Rights, said, use your sphere of influence. We all have one.
It's a good
We all have one. And I think the number of patients that have said to me, oh, I didn't realize. So I think that's education,
Yeah.
awareness and education, and vote.
And,
Vote.
and this study is helping us.
Yeah, good.
This is really helping us. And the amount of media attention that it's gotten is really, really, really helpful. What you have done, Elizabeth, and what y'all have done is incredibly helpful. What we're doing today is incredibly helpful. Thank you.
Yes.
So, questions? Start way up in the back in the red tee.
I want to thank you all for having a discussion through a statistical lens as well. What I find quite alarming is that 50% of the state does not have OB-GYNs. Is that what I'm hearing?
Yes.
So,
50% of our counties.
I guess two follow-up questions. One, did the rate of pregnancies decrease because fiscally it would make sense for us to still have OB-GYNs across the state? And two, is insurance as well as socioeconomic status has largely been left out of the discussion. So I'm wondering if you guys have statistics regarding insurance, how that's changed, as well as, you know, the socioeconomic status of the individuals that have been adversely impacted. Because unless pregnancy rates have gone down, fiscally, it would have made no sense for the fiscal-based politicians in Texas to be able to have done a move like this. So it just doesn't make sense to me.
So about 50%
Yeah.
of the births in Texas are Medicaid. Okay, I think it's just a little bit over 50%.
Yeah.
So they're government funded. I don't have statistics on what the actual pregnancy rates are. I think anecdotally, and I think Dr. Carson will agree, we had numbers of patients that came in and said, oh, wait, I want my IUD changed out. And we're like, well, you know, you've got another year or two. And no, I can't take this chance, you know. I had a patient that came in who's the wife of a physician, and she's a dentist, and they were starting IVF process. And I said, so where are you in the process and everything? Oh, we're not going to do it. And I said, what happened? I don't want to be nosy, but you want to talk about this? And she said, well, with everything that's going on, she goes, we're not going to take that chance. So people are altering plans for their family, you know. I've often said, socioeconomically, to that lens, it doesn't make sense. But it doesn't make sense for us to have a tax on contraceptive care either, because if you look at the data, you know, when contraception is provided, birth rates go down, right? It's not rocket science.
Back to my original question, have the pregnancy rates gone down in the state of Texas?
I can actually speak to
Shoot,
that.
yeah,
don't
you've
know.
got an answer over here.
Yeah, so I'm from UH Institute for Research on Women, Gender, and Sexuality, and we just put out a study this week of fertility rates based on 2023 CDC birth data. And in fact, fertility rates, we did a study right after the 2022 data came out because Texas was the only state that had a ban at that time. And we saw that the birth rate did rise slightly in Texas, and the teen birth rate went up 0.39%. But that was almost exclusively Hispanic teens. It was 1.25 among Hispanic teens, and the birth rate among other teen groups had declined. But in 2023, rates in all 50 states, including banned states and ban-free states, had declined. So this was a really interesting thing. And in Texas, the teen birth rate in 2023 went down 4.71% after going up 0.39%. So there was a big decline, and exactly what you were saying, across a lot of different stories would seem to be part of it. People are accessing abortion in other states or through medication abortion, but a lot of people are choosing not to have families that they actually would have wanted to have. So this is just such a nuanced story in terms of the chilling effect on not just doctors, but potential parents and just so many parts of it. I don't know. So this data came out last week. So so
It still doesn't explain.
Thank you.
Really interesting. The state does not have an OB-GYN because it's not just abortion based.
You,
It's health in general.
Thank you. I have a lot of questions, and I know we don't have time, but I would like to focus on the issue of the sphere of influence that Dr. Karzan was talking about. I don't know if in the Manatt survey, if you asked all the different people that you surveyed and interviewed, if they felt muzzled by their institutions, if they felt fearful of speaking up. And I'm saying this because I was working at Baylor up until last month. I worked there for 8 years in family medicine, and I even put presentations about reproductive health to family physicians. And whenever I had these talks, I could see that people were very afraid to talk about this topic. Not to mention that there are some physicians who are against abortion under all circumstances. That's also another reality. Very few, but there are. And so I wonder if the reason why people are not using their sphere of influence, like medical institutions have huge influence.
they're afraid.
Why are they not using their sphere of influence?
Yeah.
And I wonder if it has to do with funding.
Oh, yeah.
Because I know
Can you talk
They're
about that a
afraid
little?
to lose,
Yeah.
they're afraid to lose their funding. So I've lived through this. I'm on staff at several institutions. And there was a committee to get abortions approved at the academic institution where I was, even before abortion became illegal, because they had some objections, some noisy donors who said they would withdraw their support for the institution if the institution provided abortions. To the point where when abortion was legal and I had a patient with confirmed trisomy 18 pregnancy, and our recommendation to those patients is comfort care if they choose to continue the pregnancy, to allow the baby to pass peacefully. I got pushback on terminating that pregnancy. And the longer you carry a pregnancy, don't forget that pregnancy has risks.
Particularly chromosomally abnormal pregnancies.
So you are requiring a woman to take on these risks for a child that's not going to survive. Forget life, death, when life starts. I mean, that argument goes nowhere, but it's just, it's about money. They don't want to talk about it, to the point where When we filed the lawsuit to get an injunction so that I could terminate Kate Cox's pregnancy, which was a trisomy 18 pregnancy, and her situation was more complicated because she'd had 2 prior C-sections, I was talking to the leadership at the institution where I am, and they were actually very supportive. As soon as the lawyers started talking, I was no longer allowed to speak to any of the administrators on that topic.
Just to put maybe one not an answer to your question, but particularly in Texas, and this isn't dissimilar from other states. You know, a lot of the major teaching institutions are state institutions here, California, and other states, right? And so there's that dynamic. It's funding, but it's also the fact that the boards of these university systems, right? You know, they're political, and so there's that dynamic that the leaders are dealing with, or they're wrestling with that themselves. I won't get into specifics beyond that, but it's a reality of American healthcare, particularly academic healthcare, in some states that it's very state skewed in terms of control.
But even what Dr. Garcon was speaking of, I know of a story in Dallas where a woman had a trisomy 18 baby. You know, she was going to opt for what we call palliative care, and we always kind of phrase it where you let nature take its course, because just because you can do something doesn't mean you should, right? And the patient needs that option. And so she had opted for palliative care, and she asked, she said, well, I want to be delivered early because I'm a little older. I know that I can develop complications. And the institution said, absolutely not. That would have the appearance of an abortion, and we will not do that. So she ended up subsequently developing a very severe complication of pregnancy called HELP syndrome. It's severe preeclampsia. It's a variant of that where they get really sick. She was then eligible for induction. They started the induction. She had a placental abruption where the placenta, it tears away from the uterus. They rush her back for an emergent cesarean section because her goal was to have a live baby, okay, and then let her baby pass. And of course, she ended up having to get transfused. She went through all of this, and the baby was born not alive. All right. And she was telling me the story, and she was crying, and she looked at me and she said, you know, I got nothing that I wanted.
Yeah. Wow.
And that was devastating for me as a provider, right? And so I tell that story because we have too many players in the mix, all right? Physicians need to make healthcare decisions with their patients, okay? Or the patient makes the decision in consultation with the physician. So too many players.
I think we have time for one more.
Sorry.
Go ahead.
Hi, my name's Sophie. I'm a first-year medical student across the street, and I really want to be an OB-GYN, so I really appreciate y'all being here. And I also just want to applaud y'all for doing this report, because my question is really about data needs post-obs. This is so helpful. People need to see this and read this. But before I was a medical student, I was a researcher, and we talk a lot about like how we come to understand the world as it is through data. And I get really worried about the Texas Maternal Mortality Review Committee. They continuously are changing their rules. Before Dobbs, they always were putting off releasing our maternal mortality reports, which delayed data really leads to delayed remedies for injustices in care and the ways that we're maybe failing women in Texas, especially people in rural areas. I also used to live in a rural area and work there. And I wonder kind of what's the next step in this research, and how are we going to make sure that people keep getting accurate data about what's happening? Because there's so many efforts on the other side of this equation to continually produce research, huge scare quotes, that supports, you know, physicians that say, oh, we don't need this. And there was a physician recently put on the Maternal Mortality Review Committee who is also the person who's constantly going to DC and testifying, saying that, oh, abortion is never needed to save someone's life. So I wonder about that and what we can do as a medical community, but as a broader community of Houston and Texas, and just to make sure that people are getting good data.
I can speak to the MMRC.
Yeah, please.
So yes, those reports are generated, but they were withheld by the Department of Health and Human Services, not by the committee. The committee's quite functional. I know who you're speaking of that was appointed to the committee recently, And she believes that everyone that has a baby with a problem should have palliative care. She and I have spoken about this. But of course, you have to understand, some women view that as very traumatic for them. And I've had patients that come to me and said, I cannot watch my baby die. And sometimes women go through that experience and they actually require treatment for PTSD, right? So that's why I think those things need to be the patient's decision on what's right for her and what's right for her family, you know. But I do applaud our maternal mortality review committee. I know they're
working really hard. I'm talking more about like
They-
what you're saying, that the reports don't always get released in a timely manner when they're working so hard to
And
reduce this
that
report.
happened, you understand, I'm trying to be political.
Sorry.
This happened
Why?
before the last gubernatorial election, I'm gonna be honest with you, all right? And so we really had to go to legislators, particularly the state representative that represents Texas Medical Center, and said, we need your help, you know, we need your help. This is data that should not be delayed for whatever reason. And now we need to get the state to also allow us to review all maternal things, you know, even including any abortion complications. And there's a statute that says that they can't do that. But we're hopeful to get the right data.
And just on the workforce, I mean, this is the one thing that I'm thinking about every day, which is, can we move, I mean, the survey data is great, it's very helpful, but can we get to, you know, objective workforce data for the state? And the workforce data is complex, it lags as well in terms of different reporting. I'm wanting to, and some states are working on this, so we're trying to put a sort of a perspective together on how can we get better as close to real time as possible data about how this workforce, other workforce categories are expanding, contracting, how they're distributed. It's really, really complex, but I appreciate the point. We got to get better at it because we need to understand the scale of the problem objectively in the state and in communities in order to stem it further. So I'm with you, and I'm open to all brain power to help us think through that going forward. So thank you for your question.
We could go on and on.
Yeah.
This is
I'm afraid
a
so.
sadly engaging topic. Thank you, Mimi, for moderating. Thank you to our panelists, Alex for doing the work, and for you two doctors for, under really difficult circumstances, being willing to advocate for your patients. It's really important. No one can tell the story better than you. And your patients, so it's much appreciated. Thank you to all of you for coming out. This has been recorded. It'll be on the Baker website. You can use the link and send it to lots of other people, so please do that. This is hopefully the beginning of additional research that'll drive home the point that there are devastating not surprising, but perhaps unintended consequences to some of these laws. Thank you again, and have a great day.